Friends, colleagues, and dear PGTs, today we are going to resume our master class. I request Dr. Ananda Bagji, who is a new chairman of API West Bengal branch, to introduce chairperson of this session, Professor Vani Chatterjee. Ananda Bagji, please.
Thank you, Dr. Amal Kumar Banerjee, the chairman of ICP West Bengal chapter. Let me introduce Dr. Bhavani Prasad Chatterjee, who is the chairperson of today's master class, who is a senior cardiologist in the city of Kolkata. At the moment, he is the professor on HOD of cardiology, Kolkata Medical College, as well as a senior consultant cardiologist in Medica Super Specialty Hospital. He is practicing cardiology for a pretty long time, and he has got a number of national and international speakers. With these few words, I hand over the mic to Professor Bhavani Prasad Chatterjee to introduce the speaker and start the session. Over to Dr. Bhavani Prasad Chatterjee. Dr. Chatterjee, please.
Bhavani.
Yes, some problem. I think some.
Bhavani, Ashutosh, just a minute. Vani.
Yes, I can hear. I don't. I am not audible or visible. I was going on speaking. It's a great privilege to introduce Dr. Vani. He himself is an authority in the subject, and his speech on cardiac arrhythmias will bear or attest the signature of his depth and command over the subject. So without losing further time, I would request Dr. Vani to start his speech, please.
Thank you, sir. Thank you, Dr. Bhavani. Thank you, Dr. Amal Banerjee. Thank you, Dr. Anand, for the opportunity to speak at this platform. And hope my slides are well visible now.
Yes. Your slides are visible.
So it is a great opportunity, and with core of my heart, I thank to the soil of West Bengal, from where I did my DM, and it was a great opportunity to learn from Dr. Banerjee, Dr. Panja, Dr. Vishukesh Mazumdar, who was my mentor at the time when I was pursuing my DM, and by them only I can say a lot of things has been the seed has of electrophysiology I got at that institute. So not wasting much time on the particular topic, but really the most important aspect whenever we say EP, a lot of people say you should make it very simple so that everybody should understand. So I will be totally focusing on the basics, decision taking, and drug to devise an EP. All these things I will be covering, and hope so it will be as brief as possible and as pointed as possible for the cardiologist or the fellows or the general physician who are in the field of cardiology. So coming to the first, what are the presentations? So the most common presentation what we get commonly is the palpitation, and this is the complaint on which we start evaluating and making what you call whether it is a pathological or it is psychological. We make some conclusions, and in that ECG is one of the important. If a patient is complaining palpitation and ECG is normal, it goes more in favor of some stress disorder or what you call psychiatric disorder, or maybe somatization disorders which may be the patient having. But there are some other complaints which need to be addressed, and that is the dizziness and paroxysmal sweating and weakness, which are not very uncommon in patient of arrhythmias. The patient may be having fainting attacks. The patient may have sudden cardiac arrest and sudden death in the families. So this is also area which comes under the domain of arrhythmias. and dyspnea and chest pain. So if you are aware or not, I have come few patients of PSVT who complain only chest pain. And what happens when the patient grows older, the time the heart rate are going high, the patient may not be that much aware of the palpitation, but he gets some discomfort that may be in form of dyspnea and sometimes pain also. And that pain sensation may be very atypical. So he will be saying, I am getting pain all of a sudden and it goes off. So if it is happening always and if ECG is coming normal, kindly look the ECG for the pre-excitation, and whatever the patient I got in my practice who were complaining with the chest pain, they were having some WPW type of pattern in the ECG also. Coming to the syncope, so syncope, whatever we evaluate, the most important thing is the history, and the history that has to be taken in what you call the CID, means when it happened, what you are doing, how you are going, what has happened, how long lasting, who was there. Every aspect of the history is very very pertinent to make a diagnosis, and that's why whatever the mains we are having of the ECG, E-code or cardiac MRI, PET, diagnostic tool is still is the history. So if a proper history has been taken, we certainly can get the some differential diagnosis, and according to that we are going to make some conclusions what are the diagnosis of the patient. So history can't be omitted. And in the studies, even in the time when we are having a lot of armamentarium of investigating tools, history still add around 80 to 90% in making the diagnosis of syncope. And why the syncope is important? Because there are three aspects: syncope, fall, and loss of consciousness. All three are the part of the illness, and they may be having a varied name, or we can say the terminology what we use. Syncope is the technical, or we can say the medical language which we call that all of a sudden patient have the loss of consciousness with spontaneous recovery, and that should be transient. And fall is, it may be due to syncope, and loss of consciousness it may be. So if fall and loss of consciousness is associated with spontaneous recovery and it is transient, we call it a syncope. If any of the things are happening in a patient, we should evaluate whether it is a properly a syncope or not, or the loss of consciousness is due to the syncope or seizure. So like that we have to make our diagnostic evaluation. And that's why when a patient of syncope happens, most of the time they go in the neurologist, sometime to the psychiatrist, because we are not able to explain. And very few patients comes to the cardiologist. And as you know, when it comes to the intervention cardiology, they do the ECG, echo, Holter, TMT, and when they don't get anything, do the angio, and finally we say, okay, everything is fine. It does not look like to be it look like to syncope. So there it becomes very important that a proper history followed by the frequency of the syncope, or you can say the loss of consciousness, will make a lot of difference. And why it is important in clinical parlance? Because the medico-legal aspect. He has having one syncope, he has recovered, he has come to you, but it may be the last syncope. After that, it may be he may develop cardiac arrest and he can die also. That's why if he has reported to you, it is better you should evaluate, and if you are not able to get a lead, refer to a proper doctor who is going to spare some time to take a proper history, and according to the history, if any diagnostic tools are needed, starting from Holter, loop recorder, or implantable loop recorders, whatever is they are doing a invasive surgeries. Invasive procedure is also not a thing if he has injured himself during the syncope. Medical fitness, because he is having one syncope, and medical for fitness he is coming. So in that time, if we are not getting the proper ECG evaluation, we are going to miss. And if he is a driver or if it is a pilot, it may be it will have a lot of impact on the persons to whom he is carrying. Asymptomatic sudden death as a presentation. So syncope is one part, and all of a sudden this patient can die. That's why I was saying the medical legal aspect is very much attached when the patient is being evaluated for the syncope history. And as I was saying, there are few clinically markers on which we have to keep our suspicion very high. And the last aspect, if I are able to see or not. What the brain doesn't know, eye doesn't see it. So that is the important aspect. If you are not priming your eyes with the ECG findings, which may give the pointer for the syncope, you may miss it. And it is important to say at this point, you should never be carried with one ECG. You should see all the portfolio of ECGs which is available with the patients, and wherever possible, correlate, make a conclusions that possibility of a particular diagnosis. For example, if a patient is having long QT, it may not be reflecting in a particular ECG. It may be in the some other ECG, and later on you will see that long QT has been missed because the one ECG has been only evaluated. What are the basic minimum investigation when we are doing for a patient of arrhythmia? That is, one is ECG and second is echo, and these two are the minimum which give some guidance. Coming to the basics, so we are having two types of rhythm disorder. One is called bradycardia and other is called tachycardia. So coming to the tachyarrhythmias, so speed that thrills, but it also kills also. And the first and foremost, what we have to make at the outset, that whether the patient is having patient is having narrow QRS versus broad QRS, and this makes a lot of dilemma clear whether we are dealing with a he or she. So it is a male behavior or female behavior, like that it is a narrow versus QRS. You are going to make cut short the differentials in the patient's diagnosis if you are making a narrow versus broad QRS, and even the treatment also will differ, which will come across. So what do you mean by narrow? Narrow means less than 120 milliseconds, and broad means more than 120 milliseconds. So whatever is coming in the broad can have a narrow also. And tachycardia, and why it is important? Because the tachycardia which is originating above the AV node will be narrow, and anything which is below the AV node will give broad. But it is possible that narrow can become broad depending upon the conduction system. We'll come across in the later part. So how the anatomy runs. So anything which is above this one, it will be narrow, and anything which is going below is broad QRS. So signals will move very fast. We can say this is a highway. So anything which will be going, it will be very fast. And if conduction is happening with a slow pace, if it is outside the conduction system. So signals which are moving below this AV node, or you can say from the ventricles, it will be having a slow conduction, and that's why it will be broad. So that is the possibility when we are keeping broad versus narrow. But this is not the all. So sequential ventricular activation, which can happen in the patients who is having bundle branch block, means the conduction is happening through the AV node, but the right bundle or left bundle is also getting blocked, or we can say slow conduction is happening. Then again the sequential means right ventricle is going activated, and later on left ventricle, and that's why there is a broadening of QRX will be happening. Or if it is happening through the accessory pathways, means bundle of Kent is there and the conduction is not happening to the AV node, it is happening through the bundle of Kent. And as you know, bundle of Kent is a part of muscle, or we can say the part of ventricle and atrial connection. So the conduction will be not fast, and that's why it will be broad if it is happening. And that is one of the reason that patient with AVRT or antidromic tachycardia, where the conduction is happening through the bundle of Kent first and going reverse through the AV node, will be having a broader than narrow. And we know that ventricular tachycardia are mostly broad QRS. There are some exceptions that I will come across. And conduction abnormality over the His-Purkinje system. So one is sequential, which is responsible for broad, and second, if the ischemia is happening, which is affecting the conduction system, it will lead to the broad, and that's why some of the VTs are having a broad QRS tachycardia. If the patient is taking class 1C drug, which reduces the conduction velocity, so it is again leading to the broad QRS, and if the patient is having electrolyte imbalances. So broad can happen in background of narrow if the patient is having these type of problems. Coming first to the narrow QRS tachycardia. So atrial flutter, if you are knowing, that is a rhythm is confined to one chamber, and it may be left atrium, it may be right atrium, it may be left atrium, and it is a macro reentrant tachycardia. What do you mean by macro? Means it is taking a long circuit, and in our electrophysiology we say at least 2 millimeters, 2 centimeters, if we are able to put a catheter from this side to that side, and if it is the distance between two is more than 2 centimeters, it means it is a macro reentrant tachycardia for the for differentiating atrial tachycardia versus atrial flutter. So flutter can be on the right atrium, it can be left atrium, or it may be around the whatever the orifices we call the SVC ostium, or it may be to in the on the interatrial septum also. So location wise we are going to make an diagnosis, and depending upon that we are lower loop, upper loop, or RA. Second comes the narrow QRS. What we get is the AV nodal re-entry, and you can say 1% per population is having this type of rhythm and disorder. If you are diagnosing a narrow QRS tachycardia as AV and RT, most of the time you are correct due to the probabilities and how it runs. So what is happening in this type of patient, the AV node is having two pathways. One pathway we call it a slow pathways, means the conduction is happening through the low, and it is confined in the AV node on in and around the tissue. So it is taking more time going down, and then by the fast it is coming up. So the time it is getting refractive period is over, again it is going conducted. So that's why it is a re-entry circuit which has been created in the AV node, in and around AV node, and that is responsible for giving a narrow QRS tachycardia. AVRT is also one of AVRT. We are seeing atrioventricular reentrant tachycardia. So here the two, atrium and ventricle, both are the part of this tachycardia circuit, and that's why the conduction will go through the AV node, his bundle, and through the abnormal bundle of Kant, which is existing in this type of patient. We are going to say that yes, it is a AVRT. So it is more, it is having a more bigger circuit sometime, and if it may be possible that the AV node is here and the septal, what you call like bundle of Kant is there, and there may be tachycardia can happen. So the behavior will be more like a AV and RT like only, because but the location wise and the properties will be a bit different, and that's why it become important to differentiate when we are doing in the EP lab. So what we should look when we are taking a narrow QRS tachycardia. So first is the P waves, whether P waves are there or not, and more P wave before each QRS. If it is the feature, then we have to see what is the segment between the two P waves, where the P wave are located on the ST segment, so that we can differentiate between the long RP and short RP. And the appearance of the some changes in the R wave or the S wave in the inferior leads that guide us, and the ST deviation. So these are the things what we see during tachycardia. So if you are having a tachycardia ECG, you should see whether the P waves are there or not. Where to look, I will tell you. And more P wave, if you are getting 2 or 3 P waves, how the segments are in between, and where they are located if it is single P wave, and how the QRS behave when the tachycardia is happening, and what is happening with the ST deviations. So you can see this is a narrow QRS tachycardia, and in the narrow QRS, this is the QRS. After that, there is a P wave is happening. So we say that this P wave is happening just after QRS, so it is called short RP tachycardia, and in the other, the P wave is falling after the T wave at the end, and that's why it is called long RP tachycardia. And why it is important? Because whenever you are making a short RP tachycardia, you are reducing the differential diagnosis to two important possibilities. One is AVNRT and some of the cases of AVRT. So most of the other are ruled out when you are putting. And if you are not able to see any P wave, means P wave is inside the QRS. And why we are thinking that QRS P is not, if it is not here, it is inside, because as you know, for getting a narrow QRS, the conduction has to happen through the AV node, because AV node and his bundle system, because that is the fastest system. So if QRS is becoming narrow, means something is coming from the above the node, and the above the node we are having only two tissues. One is the in and around AV node, what we call as AV NRT, and other is the atrial tachycardia. So in atrial tachycardia, usually there will be a long RP tachycardia, but when the conduction is happening in and around the AV node, the P wave will go inside the QRS, and that's why it may not be visible. So most of the case of AV NRT, AV nodal re-entrant tachycardia, will either have the QRS followed by P waves, or it may be merging somewhere here, or it may be inside the QRS in the narrow QRS tachycardia. Coming to the long RP tachycardia, so you can see the P waves are here, the P waves are there, and somebody if sees, then they will say it is a sinus tachycardia. Yes, sinus tachycardia is a long RP tachycardia if it is means from the classification point of view, but the morphology is very, very important. So if the morphology is changing during the tachycardia, we say that the focus has changed from the sinus node to in and around the crista. We call as a crista terminalis, where the sometimes the morphology will be almost same, and it is the rate and the behavior which makes the diagnosis. So sinus tachycardia is a long RP tachycardia, and you can now see the second ECG here. Somewhere the P wave is falling. So the best way is just put a line, straight line after the QRS. You are able to see the P waves, and the morphology of P wave will make a lot of difference. So whenever you are getting a inverted P wave in the inferior leads, this is a 2, 3 and AVF. So when the P waves are inverted, it speaks that conduction is happening from the lower to upper. Means the P waves are going from low to up, which is against the rule when the sinus is there. The sinus, always the conduction will be happening up to down. That's why 2, 3 AVF will be positive. So if P wave is negative, it speaks that the conduction or the tachycardia is coming somewhere from the lower to upper conduction is happening, and it can't be anything else other than the AVRT, AVNRT or atrial tachycardia originating in and around the nodal tissue. Coming to the short RV tachycardia, while seeing the ECG, you can say the patient, he or she is having AVNRT, and you can see in this patient. So here the QRS is narrow, first thing what we are seeing, and the P wave is falling just at the end of the QRS. So this possibility can't happen in any of the patient who is having AVRT most of the time, because the tissue, the P wave genesis will need at least the tissue has to conduct through the atrial before getting P wave formed. So the narrow, you can see this is a narrow P wave, and that is falling just after the QRS or splintered to the QRS. So if you are getting this thing, until proved otherwise, you can just put the diagnosis AVNRT, because this is not possible most of the time in the AVRTs. AV nodal re-entrant tachycardia will not have this type of pattern. So if you are getting a splintered QRS, or you can say the R wave in the V1 and S wave in the inferior lead, it is a mark of AVNRT, AV nodal re-entrant tachycardia. While in the patient of AVRT, we can say there is a P wave which is falling somewhat away from the QRS. So this is the major difference. Sometimes the rules, if the AVNRTs means AV nodal re-entrant tachycardia can have the P wave falling away from the QRS, we can say short RP, but still it is not splintered. But if it is splintered, it is a AVNRT. But if it is not splintered, it can be AVRT, AVNRT, both can be possible. And the important point, sometimes we miss, and sometimes this, if he's an elderly patient and who is coming with a chest pain, everybody see this pattern and think about is a high risk ACS, and they do the angiography and then they turn out to be normal. So important point or learning is that if you are getting a particular type of ST depression and that is confined to the lateral lead with a narrow QRS tachycardia, it is a mark of inverted P waves, which is giving impression of ST depression. So this ST depression, which is happening in the lateral leads, or you can say the anterolateral lead, is a mark that the patient is having anterolateral or patient is having left lateral pathway. So we can decide from seeing this ECG that the P wave is not exactly splintered to the QRS, and you are getting the ST depression. So these two findings favor the possibility of AVRT, number one, and second, it is due to the left lateral pathway. So now this part is over, means 1P followed by 1 QRS. The possibility is AVRT, AVNRT, and cases of atrial tachycardia also. And we differentiate from one maneuver we call as giving adenosine. So if the adenosine is terminating the tachycardia, we say that it is a AV nodal dependent tachycardia, and the diagnosis is AVRT versus AVNRT. And 6% of patients with atrial tachycardias can have termination of regular narrow QRS tachycardia. In that also it is going to respond to adenosine. So AV dependent versus AV independent tachycardia we differentiate by doing the adenosine. Most of the time when we have been taught regarding the flutters. So everybody starts seeing and they say it is a flutter is going on. But the flutter pattern, if you really want to know or understand, the first rule, whenever the tachycardia is regular tachycardia at rate of 150 is ongoing, we say that the P wave is inside the T wave. And as I was saying, if you are getting a narrow QRS, means the conduction is happening above the AV node. And if a regular tachycardia is happening, means P wave is somewhat here. So it may not be visible, but we take an impression that a regular tachycardia at rate of 150 means the heart rate is around 300, and 300 heart rate is of the flutter. So you can see the P waves are falling inside the T waves, and that's why the ventricular rate is 150 and flutter rate is around 300. So P wave more than QRS. Again, you can see here the flutter is running, and you can see there are more P waves. So this patient is having a flutter running, and some of the flutters has been conducted, and it is going to the right to the ventricles. So now coming to these things we have discussed regarding the regular. So if you are getting a narrow QRS tachycardia and irregular, so what is the possibility? So it is very easy to diagnose, and we can say you are getting somebody say that it is a flutter, but one thing, a word of caution, when you are getting not a singular morphology of P wave, it is a fibrillation, not flutter. So when you are getting different P wave thing, and it is not confined to most of the lead, it is only one lead, it is we can say coarse atrial fibrillation. It is an older term, but nowadays not used, but it is a coarse AF which is running, and the most important thing is the QRS is varied, means there is a irregular RR waves. And when we are diagnosing atrial fibrillation, the strategies should be clear. So I know everybody knows how to manage rate versus rhythm depending upon the patient's disease. We have to take call, and how the left atrium, right atrium, and what are the comorbidities, and what are the other drugs. We have to take a call. Most of the time we want to go for the rhythm control wherever possible, but if the patient is in the persistent or permanent AF, the rate is still a good choice. But important thing is, whenever you are seeing the AF patient, you have to put the patient on the anticoagulation. And this slide is very important, because we should know where we have to put anticoagulation without seeing the Chadwick score. Means non-valvular AF, nowadays this terminology is not used. So if your non-valvular AF and Chadwick score is more than 2 for the male and more than 3 for the female, depending upon the ESC and ACC, there is some differences. You have to start the anticoagulation. But there are 3 conditions in which you are not needing any Chadwick scoring. Number 1 is valvular heart disease, particularly mitral stenosis, and if it is severe, there is no need of doing the Chadwick scoring. Second is hypertrophic cardiomyopathy, If the patient is developing paroxysmal or persistent AF, you have to start anticoagulation. You have not to wait for the Chadwick score. And third, the amyloid heart disease. So if the patient is of amyloidosis, they are having a high coagulability index, and those conditions we have not to again go for the Chadwick scoring to put the patient on anticoagulation. So P waves are there, and these P waves are, you can see, having different morphology. So when the P waves is having different morphology, we call that the P wave is coming from the different locus, and since the morphology is changing, we call that it is a MAT, multifocal atrial tachycardia. And this condition is mostly associated with metabolic and respiratory disorders. So irregular QRSs are coming. Always try to look for the P waves. And if the P waves are changing the morphology, we should put a diagnosis of MAT over the atrial fibrillation, because the diagnosis makes a lot of difference. If you are labeling this patient as atrial fibrillation and long-term anticoagulation, he may not be needing as per the guidelines. And it is more a terminal illness feature than structurally abnormal heart. And when we are giving the adenosine, after that we should always look back what is happening to the baseline ECG, means when the patient is coming to the sinus. So you can see the delta waves are there in the we can say V1 to V6, and at the same time there is a short PR interval. So this is a case of WPW syndrome. So in nutshell, if narrow QRS tachycardia has been diagnosed, that is QRS is less than 120, the second thing what we have to see is whether it is a regular versus irregular. If it is a irregular, we are having two important possibilities. One is atrial fibrillation, when we are not getting any P wave, or patient is having atrial flutter or atrial tachycardia with variable AV block, that is second possibility. And the third is MAT, so multifocal atrial tachycardia. If it is a regular, look for the P waves. If you are not getting P wave, diagnosis is AVNRT. So AV nodal reentrant tachycardia is the possibility. If you are able to see the P wave, just see whether the atrial rate is greater than ventricle or not. So atrial rate is greater than ventricle, yes, then it is a atrial flutter of atrial tachycardia. These are the two possibilities. If it is 1-to-1 conduction, means number of atrial and ventricle means more, and similar number of P and QRS, then analyze the RP interval. And if it is short, and if it is shorter than 70, what I was saying is splintering is happening within the 70 seconds, it is happening. It is AVNRT, AV nodal reentrant tachycardia. So it is a curable conditions where we can say that yes, let the patient go directly for the EP study, not to put the patient on the drugs. Or it may be long RP more than 70 milliseconds, then the possibility is AVRT, AVNRT, atrial, either of the things can be possible. And long means PR is longer than RP interval, then the atrial tachycardia, PJRT, paroxysmal permanent junction reentrant tachycardia, and atrial atypical AVNRT can have this type of pattern. So, and what next means, if you are not able to differentiate and you want to know whether we have to give adenosine, what will the behavior? So if there is no changes happening after giving the adenosine, or your resident is saying that still it is going, so there are two possibilities. Number one is inadequate dose and not properly delivered, means the saline has not been pushed at the right time, or the adequate quantity of this adenosine has not been given. So in that situation it can happen. And consider the VT. So there are two VTs which has to be considered when you are dealing the narrow QRS tachycardia which is not terminating, or we can say with adenosine, or which is not AV nodal dependent. So one is the fascicular VT, or any VT which is coming from the septal tissue. So high septal tissue will be having the same morphology as the narrow QRS tachycardia of AVRT, AVNRT, and that's why it may mimics PSVT, which may not respond to IV adenosine. So fascicular VT and high septal VT are the two conditions in which adenosine may not respond even after giving the adequate dose. Coming to the second, the QRS is getting wider, or not to say wider, slower, and after that again it is bumping up, means accelerating. So what are the possibilities? It is a sinus tachycardia or focal atrial tachycardia or non-paroxysmal junction tachycardia. These tachycardia will have the behavior of slowing down and again re-acceleration. And if it is terminating, it means that it is dependent on the AV node like AVRT, AVNRT. And sometimes the sinus nodal re-entry tachycardia and focal tachycardia also terminate. What I was saying, around 6% of the atrial tachycardia also can terminate by giving adenosine. So making a possibility of AV nodal re-entrant tachycardia. And if the tachycardia is still persisting without any change in the rate, the diagnosis is atrial flutter. So you can see that time the PP interval between the, which has been masked by the QRS when you are giving the adenosine. So you have given adenosine and you can see the P waves are running. So this is a case of atrial tachycardia. Now, what is the narrow QRS tachycardia? What is the treatment? Everybody know regarding beta blocker and calcium channel blocker, but yes, this type of patient can be given the ablation, and ablation is a curative treatment in this type of case. What we do, we take 3 catheters and 3 locations. We can say the one is the coronary sinus we keep, one in the his position, means AV nodal location, one in the RV, and sometimes we use the high right atrium position, and by that we are going to locate where the tachycardia is happening, and after that we terminate it, after that we ablate it. So these are the 3 positions of the catheters. One is the coronary sinus, RA, RV, and this one. And after that we are going to analyze the catheter position when the tachycardia is happening, where this QRS is getting fused, which give direction which is happening, and what is the pattern of the conduction. Regarding atrial flutter, fibrillation, and atrial tachycardia, means we can say the non-AV nodal tachycardias. There we will be needing the 3D mapping. 3D mapping is something we call as we are keeping some patches on the chest, and we want to analyze the 3D geometry of the tachycardia. By the color coding, we will be knowing where the tachycardia is coming, and that location we will go and ablate it. So that is the way the 3D works, and the 2D, it is more a fluoroscopy, means we are putting the catheters in the system. By the computer system, we are seeing the conductions, how the conduction is happening, A, H, and V conduction is, and where it is fusing, means here the short circuit is happening, or you can say the bundle of current is in and around the CS catheter, means somewhere here, and then we go in that location and give the ablation energy or RF energy, and we come out. Here it is totally different. We make a 3D anatomy, we see the electrical activation pattern, and finally we locate the exact location, and after that it gets operated. Coming to the part 2, that is a broad QRS tachycardia. So what I was saying, if you are getting a regular broad QRS tachycardia, the possibility will be ventricular tachycardia. All the supraventricular tachycardia, what I have discussed, if it associated with bundle branch block, it will be broad QRS. And AV nodal antidromic AV re-entry tachycardia, what I was saying, AVRT, if it is going through the AV node, we call as a orthodromic, and if the conduction is happening first through the pathway, or you can say bundle of Kent, and going up by the AV node, we call as antidromic. So these are 5% of the patients, 5 to 10% of patients who will be having WPW pattern, and they will be presenting as broad QRS. If broad QRS is happening, means antidromic conduction is happening. If it is happening with irregular broad QRS, the torsade is the one of the commonest possibility, LBB with atrial flutter fibrillation, or WPW with flutter and fibrillation. So these are the possibilities which can be in the patient with broad QRS. And what are the questions to be answered before analyzing the ECG? So if you are making a broad QRS, what I am saying, he versus she. If it is a broad QRS, see the hemodynamics. And the second question that you have to answer, whether it is a monomorphic versus polymorphic. So there we are having short RP, long RP, and broad versus, and depending upon that we are keeping the possibilities and uh, the possibility that how it is going to behave with the adenosine. So here you can see that is a almost irregular tachycardia is happening. There is some narrow also, there is some broad also. So these are the situations where we have to resist to give adenosine. You should not overlook that, okay, there are some narrow QRS is there and it look like to be narrow here, so let us give adenosine and diagnose the patient. You will lose the patient and lose the patient on table if you are not ready with the what you call managing the cardiac arrest, because this is a patient we can say pre-excited atrial fibrillation. So always hold yourself for giving adenosine in only one situation we call as you are still not clear whether it is narrow or broad, or and there is a irregularities going on. So irregular, broad, narrow, both are ongoing in the same tachycardia. It is until proved otherwise. It is a pre-excited atrial fibrillation, and in that situation, you should never give adenosine because it will go convert into the VF, and the patient will die on table. So this is the situation. I will caution everybody that adenosine should not be given. Second, coming to the polymorphic VT. So you can see the morphology is not same. Here it is up, up, down, up, and somewhat broad also. And again, there is a sinus rhythm has come, and after that, it started uh, having a different morphology. So we call as a polymorphic tachycardia. And here you can see a singular morphology is ongoing. Though it is broad, but it is a singular morphology. So it is a monomorphic. So monomorphic versus polymorphic, that makes a lot of difference in our decision taking. So if you are dealing with a polymorphic VT, uh, so in polymorphic VT, sorry, polymorphic, the cause is more metabolic or ischemia, while in the narrow QRS, sorry, in the broad QRS regular, the possibility of monomorphic, it may be a scar VT or it may be uh, what you call RVOT VT, that are the possibility. So during tachycardia, what we call as a rule of thumb is that application of differential VT SVT is only if the patient is hemodynamically stable. Then only you should go. Look for the baseline ECG if it is available, and look for the clinical background. That makes the differential diagnosis important. There are a lot of criterias are there, and I still feel that whatever criteria you are using it, you will ultimately land into the diagnostic dilemma whether I am correct or incorrect. But there are something we call as a high specificity criterias. So one is the AVR lead. If you are analyzing and if you are getting a presence of R wave, means the AVR is positive, which is usually negative. So it is a diagnostic tool. If you are dealing with the dot QRS, it makes you very clear that you are dealing with VT. And why I am saying AVR positive means conduction is happening from the apex of the heart and going up. So which is not possible other than the ventricle, which is giving the beat. So if you are having abrasion, what is called supraventricular tachycardia with LBB or RBB abrasion, AVR will never be positive. So if you are getting an initial positive R wave, it is a diagnostic of ventricular tachycardia, and that is one of the underpinning for very criteria which has been one of the recent criteria for differentiating. Other than breadth of the QRS, which is more than 40, means the initial part of the conduction is taking more than 40 seconds. And if you are getting a notching in the initial downstroke or negative QRS, that is also. And this is the foundation that if you are the initial versus terminal part is more than 40 millisecond, it very favor of VT. And first, if anything is getting taller, first sign in the VT, that is also. But still, you are not able to make any diagnosis. Can we simplify further? So just look for only one lead, that is a lead 2. And in this study, they have found that the if the starting from the R wave to the peak of the uh, uh, R wave, if it is happening more than 50 seconds, again the foundation is same. If the initial part of the QRS is taking more time, it means it is coming from ventricle. Because if it is happening from the supraventricular, as I was saying, the his bundle system is a very fast conducting system, so this will be always narrow in the initial part, or it may take the peak will be very fast going. If it is taking more time, means the conduction system is not involved, it is coming from the ventricle. So it is until proved otherwise, again in favor of VT. And why I was saying not to use too much time if the hemodynamic is unstable, because these all are having a very low sensitivity. And when the patient has been terminated from the tachycardia, we have to look again for the conditions which may be initiating this tachycardia, if it is a regular tachycardia or irregular tachycardia. And you can see there are always some pointers for the particular disease. And if you can see, there are 4 things. In the ARVD, you are getting the epsilon wave at the terminal part of the QRS. There is a Brugada pattern in the V1 lead, and malignant early repolarization syndrome. You can see it is more look like to be somewhat J wave elevation. And some of the patient, there may be the long QT syndrome. So these are the possibilities. When you are terminating, always look for the patient's ECG. If it is available earlier, always have a look. And I was saying regarding the history, why it is important. So it was a very long back done study by Dr. Akhtar in Milwaukee. So they found that if a patient is having myocardial infarction, the white QRS tachycardia will 98% time it is a white tachycardia will be VT, but only 7% of SVT will have the history of a myocardial infarction. So history will just diverse the diagnostic from this side to that side if you are dealing with a white QRS tachycardia. So if you want to make the things very easy for everybody, initial R wave in AVR, longest R to S, what I was saying, the Josephson sign if you are getting, or initial R and Q is more than 40 milliseconds. These 3 are important differentiating signs in the ECG which points towards the ventricular tachycardia. What next we have to do? Acute cardioversion and then put the drugs, and definitely it is ICD or ablations. Now, how to choose which patient we have to go for the ablation and which patient you have to go for the what you call device therapy. So, making the things easy for everybody, if the patient is having VT with normal heart, so there are 2 possibilities. It may be with the we call as a channelopathies, where you will be getting some pointer like Brugada pattern in the V1 to V3 or epsilon in that, or long QT. In that patients, we have to go for the ICD implantation. And if you are getting a particular morphology or singular morphology coming from a particular location like RVOT, LVOT location, so or even the fascicular VT, we are going for the ablation as a treatment. So in all this condition, if you are doing the echo, that will guide, and if you are doing cardiac MRI, it will be diagnostic that patient is having no structural heart disease, monomorphic VT is going, ablation will be the treatment. If the patient is having channelopathy like Brugada or long QT, it is ICD. Coming patient with the abnormal echo, or patient is having coronary artery disease, or patient is having MRI done and showing the scars, the treatment will be in that situation will be ICD. ICD will the first, and if the patient is getting a recurrent shock or VT episode, then only we are going for the ablation. Usually there's a diagnostic dilemma. Most of the time, interventional cardiologists and electrophysiologists, they try to pull the case toward each other, and sometimes the residents are very much confused whether it is a VT case, whether we have to go for the electrophysiologist or cardiology or intervention. So this question is need to be answered: angiography first or EP first? So there is a rule what we call as if a patient is having a polymorphic VT, it is more ischemia driven if it is associated with chest pain, or it may be a metabolic cause, what I was saying, the hypokalemia or hypomagnesemia or electrolyte imbalances. The polymorphic VT will be happening. If the patient is having monomorphic VT, means there is a circuit, or you can say there is a substrate which is driving the VT, and in that situation, after stabilization, we should go for the ablation versus ICD implant. So coronary angiography, go for revascularization. So it is what I was saying. If the ischemia is driving, it will be a polymorphic VT, and if it is a monomorphic VT, it is a scar driven. So in this situation, the ICD will be the treatment, and if the patient is having ischemia as a driver, do the angioplasty, come out. So if the patient is having chest pain ongoing and he's throwing VT, that VT most of the time is not a monomorphic VT, it is a polymorphic VT. And the time you are opening the vessel, the chest pain will be also relieved and the VT will be also over. And in that situation, the coronary angioplasty will be the anti-arrhythmic for that patient. So whenever you are dealing a case of polymorphic VT, first defibrillate the patient, and if it the ischemia which is driving or metabolic, correct it. It may be rarely with the prolonged QT syndromes in which the patient may be throwing if the patient is not having ischemia. And first and foremost, when you are dealing polymorphic VT, you should take out the offending drug, replete the potassium, give magnesium even you are even the magnesium level are not available or even normal also. It works as antiarrhythmic. Consider increasing the heart rate so that the beat to beat differences and initiator for what you call polymorphic VT should be reduced. And in the after treatment, if the patient to be kept on the beta blocker in the congenital. And if patient is having structural heart disease, means LV dysfunction is there, coronary artery disease is there, the patient is developing polymorphic, monomorphic VT, he should be given the ICD. And if patient is developing recurrent VT, then we are going to locate by the 3D mapping and later on we ablate it. So that is the way we do for the. So drug decision, what are the things we are going to see? So polymorphic versus monomorphic, the first thing we have to see, and QT interval and channel markers. So ECG will give how the QT is and whether any channelopathy, means Brugada, long QT, anything is there or not. And LV function, means if the patient is having severe LV dysfunction, VT is happening, ICD is the first therapy, later on ablation if needed. And the patient angiography will certainly give two answers, whether the ongoing ischemia in the acute crisis, or you can say acute coronary syndrome, is caused for the polymorphic VT, open the vessel as antiarrhythmic, or the patient is having coronary artery disease, need to undergo ICD implantation if he is having already cardiac arrest with that. One drug everybody is knowing when it comes for treatment, and we call as amiodarone. So amiodarone is the one drug you can give left and right where you are seeing SVT, VT, atrial flutter, fibrillation, but where not to give. So if patient is having long QT, if you have given, then you have bring the problem for yourself. The patient will have the lot of VT episode throughout the night or day after giving, or if you are loaded, the life is difficult for next 24 hours. Torsad means long QT, polymorphic VTs in background or long QT, you should never give. And white QRS tachycardia, baseline ECG with delta wave. So if you are having, we call say WPW syndrome, and you are getting delta wave, and patient may be having atrial fibrillation flutter ongoing, their amiodarone most of the time people give, but the drug is ibutylite. So ibutylite blocks the conduction through the bundle of Kent, or we can say abnormal pathway, and that is the drug of choice, not amiodarone, because amiodarone is having initial beta blocker function, and later on comes the class 3 function, which is its function for which you utilize. So it should be avoided. Coming to the bradycardia. So I think most of the part has been techie is over. Now coming to the brady, and hope I am with time, 15-20 minutes more to cover. So bradycardia means everything is slow. Bradycardia means block. So block can happen at SA node. It may be generation block, which we call as in 6 sinus syndromes. Generation, but no conduction in the elderly, or it may be conduction is happening, but it is reaching to AV node or his bundle. There is the block is happening, and everything is fine, but still the heart rate which it should pace, it is not happening. We call as a chronotropic incompetence. So these are the 4 form of bradycardia which can happen and which may be one of the reason. If coming to the AV conduction disorder, so first degree block, second degree type 2 block, and third degree. I don't think it is very difficult to diagnose, but if you really want to make it simple, more P than QRS, yes. Fixed PR interval, then it is second degree AV block and it is MOBIS 2. So fixed PR and you are having more P than QRS, it is a type 2 AV second degree AV block. If PR interval is not fixed, we are having 2 possibilities: whether the QRS is regular or whether the QRS is irregular. If the QRS is regular, the diagnosis is third degree AV block. And if the QRS is irregular, it is the second degree AV block, MOBIS 1, what we call as a Venki-Bex. So this is one of the reason for what we call as a group beating. So when you are getting a particular pattern, 3 beats coming, then gap, 3 beats coming, 1 gap, means it is a Venki-Becking is happening. So PR fixed, MOBIS 1, PR not fixed, see the QRS pattern. If QRS is also fixed, at a it is a third degree block. So you can see. Coming to the trias, means when the block is happening, when you have to rush to the what you call cath lab to put a pacemaker versus a condition where you can wait for some time, give some drug, call somebody. So you are having 2 type of pattern. Here you can see there are P waves are there, QRS 2:1 block is anyhow going on, and it is almost like a complete heart block. And here also the same thing is going, but what is the major difference in these 2 things? Here it is a narrow QRS and here is the broad QRS. So the first and foremost reflex everybody should have, that when they are dealing with a block, what is the behavior of the QRS? If it is broadening, means you can lose the patient anytime, and this type of patient you should immediately push to the cath lab, put a temporary and come out before discussing anything if possible. Because in this, if you are taking too much time, you may lose the patient on table or while examining also. So he may have come from home doing fine or with some symptom, and all of a sudden he start gasping. But this type of patient will not, because the narrow QRS means, again, the same principle, the escape rate is coming in and around the AV node, and that's why it is narrow. So 6 sinus syndrome, I don't want to go in detail. Yes, the sinus bradycardia less than 40, sinus RS more than 3 seconds, and if it is a atrial fibrillation, we take as a 5 seconds. But this criteria has been now revised, and chronotropic incompetence. Sometimes it is associated with atrial flutter fibrillation. The time you are terminating the patient will go in the asystole. So they are having the 6 sinus syndrome on the background. And the treatment is bradycardia, wherever the bradycardia is there, and if it is symptomatic, put a pacemaker. And I think West Bengal is the center of excellence for all the pacemakers innovations and the highest number of cases. So I know everybody is knowing about the pacemaker, when to put and what are the conditions. I will walk through some cases which are interesting, and this is one of the interesting cases. He is around 52-year patient who presented with giddiness, some giddiness, and he has been referred to me. And 3 cardiologists has already told that you have to go for the pacemaker. But I looked this patient ECG, I find something very interesting, that probably maybe it has been missed. And if you can see, there are the P waves which is inside the T waves. So this type of condition, and he is almost 2017 he came to me. So that time I was just practicing in care hospital, and I was not knowing what to do. And I have taken this challenge. I put the patient on beta blocker, so which is a drug which is contraindicated in this type of condition. And later on the patient recovered and he went off, and the reason was, sorry, this is we call as a premature atrial beats are coming, and so we have to suppress it. And to suppress, we are having calcium channel blocker or beta block. I told that your symptom may increase or decrease depending upon that. And thank God that patients, whatever the extra beats are coming from a particular locus, it has been reduced and the patient's sinus rhythm has gone up. So that was the diagnosis. And this was, I was saying, whenever you are seeing the rhythm, always see the QRSs in a different pattern. If you're getting a particular pattern, everything is regular, and the P is married with the QRS, the regular sinus rhythm. If P is followed by and morphology is changing, the premature beat, slowing down and speeding up, pauses are coming, and this is the pattern what I was saying. Diagnostic of Venki-Beck means group beating, 1 2 3 dropped, 1 2 3 dropped. Any irregular, you know the diagnosis. Two cases which is in our practice which I have come across, and it is very interesting. So I will just put, if panel allows me, it will take 5 to 7 minutes more. So she's a 16-year-old girl who has come to me, and he has been referred by one of my cardiologist colleague. He told that he is having short PR interval, and her history is that for last since childhood, she was, while playing, she get unconscious for some time, and she was put on the anti-epileptic for almost 10 years. For 5 years she was not doing well, means even after taking the anti-epileptic she was not doing fine, and she has been referred that the PR is short. I think she may be having some tachycardia. Why don't you do the EP study and diagnose the condition? So I was very much convinced whether PR is short, it's okay, but whether any broadening is happening or not, or any conduction, we call as a, she was not having money to even invest for going for EP study. So I put the patient on the TMT. And TMT is a very important tool. Whenever you will be surprised, a lot of diagnostic dilemma can be cleared. Either it is a long QT, or it may be exercise-induced VT, or the patient with this patient. So what I learned during my DM time, that time Dr. Mazumdar was saying that you can diagnose patient of one condition, and what is the condition, he told me to go and learn. That time I didn't told, and same time this patient was having VPCs start coming, and after that VPCs are going up, and this is the polymorphic VT the patient developed, and after polymorphic VT again it is reverting, and the bidirectional VT, what I was saying, very diagnostic of CPVT. So this patient was having the CPVT, so catecholaminergic polymorphic VT, which can be labeled by diagnosing by TMT. The heart rate at 110 will start throwing the VPCs, and the time the heart rate is going up to 130 or 140, 125 to 130, the patient will start running the VT. So very, very typical. If you are suspecting somebody who is developing exercise-induced collapse, kindly consider this investigation with proper preparation that may develop VT needing defibrillation, and you can diagnose. And this patient was put on the propranolol and flecainide, and after that the patient is doing fine, no VT. It is going to be 3 years down the line. Second patient is having this giddiness, syncope, cough, treated with the following drug. 25 times DC shock has been given, and you can see that the polymorphic VT is going on. And that's why I was saying, whenever you are getting a polymorphic type of VT, never give a amidron. Amidron is a nonsense drug for this condition. So in this, you have to remove the offending drug which he was taking, that is amidron. Replete with the potassium, which was low in this patient, around 3, and 3, which has been depleted to 4.5. And never ever hesitate to give the magnesium. People give, doctors give 1 or 2 grams and say we have given magnesium sulfate. you can go up to 12 grams over 24 hours if the patient is having normal renal function. And even if you want a very fast recovery of this patient, put that patient on temporary pace with 80 or 90 heart rate. You can tide over this type of torsades induced polymorphic VT. And this already I have told. So this is one more and the last case. That is a 46-year-old patient, recurrent palpitation, failed on adenosine, 12 milligram was given, not responded, and finally somebody told, why don't you give a diltiazem? So diltiazem was given, and after that patient has been normal, and you can see, and there is a T wave inversion. So the patient underwent the angiography, and after angiography everything was normal, and they told you may have to plan something worldwide. So here the one thing what I just wanted to impress. So whenever you are getting a RBB pattern with left axis, or we can say RS pattern, or in the inferior lead, it is a mark or it is a stamping diagnosis for fascicular VT. So if adenosine you are giving in an adequate and a proper way and it is not responding, always try to scratch the possibility or scratch your mind that probably you are dealing with fascicular VT. Go with calcium channel blocker, either it is a diltiazem or verapamil. Immediately, this is called verapamil responding tachycardias or ventricular tachycardias. So in this type of situation, give a drug, it will respond, and if you can put on the drug, the patient will be, and this is the mark whenever the patient will be having pathway or where the ventricle is the part of the circuit, or you can say the T wave inversions will be coming. So when we get a T wave inversion after narrow QRS tachycardia, we keep the possibility of AVRT, AV nodal, atrioventricular reentrant tachycardia or ventricular tachycardia. So it is a fascicular VT. That's why you are getting a T wave inversions. So this already I have already discussed. So coming to the take-home message for our today's presentation. So label the arrhythmia first, whether narrow versus broad. Keep a differential diagnosis wherever possible. If you are dealing with wide QRS tachycardia, check the hemodynamics. And after making the patient into the sinus rhythm, always plan the definitive treatment. In a narrow QRS tachycardia, it may be the ablation which may be curative, and always give the domain that treatment, refer the case to the domain so that they can give the curative treatment. And if it is a case of a VT in a scar VT, it may be needing device therapy to prevent the second sudden cardiac arrest type of episodes. So with this, thank you so much for giving your attention, and if you are having any question, I will be happy to answer. Over to moderator.
There are certain questions in the chat box.
Yeah.
Would you like to directly take up?
Yeah. I can't start my video. I am Dr. I think, yeah. Relationship atrial size and atrial fibrillation. Okay. So size has got some relation with the morphology of the what you call relations of atrial size with atrial. So if the patient is having left atrial dilatation, the chances of atrial fibrillation will be high, and this is one of the reason of even we call as a HFpEF. The patient is having left atrial dilatation and they are having more atrial fibrillation. And this is one of the criteria also, one of the what you call risk factor also, scoring system of HFpEF. So if you want, yes, atrial size, whenever it is getting larger in the size, more possibility of atrial, and the atrial fibrillation which will happen, it will be more persistent and permanent than paroxysmal. So its behavior changes if the left atrium is dilating. Drug of choice for supraventricular tachycardia, known case of pre-excitation. Okay. So usually beta blocker we prefer, beta blocker, calcium channel blocker we prefer in absence of WPW syndrome type. If you are getting a WPW syndrome, Most of the patient doesn't have any problem with a beta blocker or calcium channel blocker, but that is not the preferred. The class 1C drugs are the preferred. That is the flickerite, flecainamide that should be given if they are not ready for ablation, because ablation is the curative treatment and it should be given wherever possible. Can we give diltiazem in heart failure? So we should know that sometime patient with ongoing tachycardia for prolonged period may develop tachycardiomyopathy. So a patient with a fascicular VT or patient with atrial tachycardia can present with heart failure where the tachycardia is driving the failure. The time we terminate either by diltiazem or emitron or by shock, the function recovers. So in that, the diltiazem may not be the contraindicated drug. It may be a drug of choice in that situation. But keep a possibility that patient may deteriorate if the patient is having a prolonged illness due to some other reason also, where the tachycardia is also add-on. Like atrial tachycardia can happen in a lot of terminal illnesses, and that time if you are going to correct the atrial tachycardia with diltiazem, it may not be a good choice.
Also, I would like to add that if it is not systolic heart failure, diastolic heart failure, which the questionnaire has not specified, in that case also diltiazem will be recommended definitely.
Yes, yes.
Any other question?
Yes. This question is from internal medicine point of view. What is your message while writing Holter monitoring, advising Holter monitoring? Suppose a patient comes with features of transient loss of consciousness and a battery of tests are done, but not all patients require Holter monitoring. ECG resting ECG is normal, and we are suspecting that probably the patient might be having some arrhythmia or like that.
Regarding this thing, detailed interrogation and elicitation of the history may reduce the number of investigations. Loss of consciousness in the background of what palpitation or nature of palpitation can give some clue to the presence of arrhythmia. In that case, we can avoid the heavy test or the things like that. But if it looks like the scenario is like that of a vasodepressor 1, in that case, detailed invasive investigations definitely will be avoided. And
another question, Dr. Vani.
For those